Hello, this is Mirrakhimov speaking. I'm one of the cardiac anesthesiologists at the University of Kentucky, and today we'll be discussing neuroleptic malignant syndrome and serotonin syndrome. These are high yield topics for the ABA exams, and sometimes you can see and take care of these patients in the intensive care unit. I have no conflict of interest regarding this presentation. Please take your time to review the disclaimer for this presentation. So the agenda for this talk is to discuss neuroleptic malignant syndrome and serotonin syndrome. We will do this by reviewing the epidemiology, etiology, clinical presentation, diagnosis, and management. We will start with neuroleptic malignant syndrome, or NMS. It is a rare condition. It is present in up to 3% of patients taking neuroleptic medications, such as antipsychotics, for example. If not treated and recognized, unfortunately, NMS is associated with morbidity and mortality. So the etiology of neuroleptic malignant syndrome include different medications. The common aspect of those medications is their ability to block dopamine receptors. For example, antipsychotic medications such as first-generation antipsychotics, such as haloperidol, as well as second-generation antipsychotics such as clozapine. First-generation antipsychotic is associated with a high risk of NMS. Other medications which block dopamine receptors, such as, for example, metoclopramide, promethazine, and droperidol, are also possible in inducing NMS. Medications such as levodopa, which are used in the management of Parkinson's disease, can also be associated with NMS, but in the case of levodopa, is usually due to withdrawal of the medication. Also, intrathecal baclofen withdrawal will usually lead to a very similar clinical presentation. The pathogenesis of NMS is very complex. To simplify it, it is usually associated with decreased dopamine 2 receptors and dopamine 2 signal in the brain, dysregulation of the sympathetic system, and reduced GABA or gamma-aminobutyric acid activity in the brain. So there are some risk factors for NMS, such as, for example, use of high-potency agents, such as, for example, haloperidol, as well as flufenazine and risperidone. Depot formulation, such as, for example, depot formulation of haloperidol, is also associated with high risk of neuroleptic malignant syndrome. And also concomitant use of lithium, for example, for concomitant schizoaffective disorder, is considered to be a risk factor for NMS development. Clinically, it usually takes time for the NMS to fully evolve or develop itself. Usually takes several days. Typical symptoms and signs of NMS include mental status changes, ranging from agitation to coma, extrapyramidal symptoms such as tremor, dystonia, dysphagia, and rigidity, hyperthermia. Approximately 40% of patients with NMS have profound temperature elevation higher than 40 degrees Celsius. Also, it is associated with autonomic instability, such as hypotension and hypertension, and various arrhythmias. Neuroleptic malignant syndrome is primarily a clinical diagnosis. Laboratory workup is important in screening for complications of NMS or possible alternative conditions. For example, elevated creatine kinase or CK levels may indicate rhabdomyolysis, which is unfortunately common in patients with NMS. Other abnormalities may include leukocytosis, which may or may not be related to infection, increased liver enzymes, different electrolyte abnormalities, acidosis, and acute kidney injury. The differential diagnosis of neuroleptic malignant syndrome is broad, and it includes malignant hyperthermia, serotonin syndrome, which we'll discuss in a bit, anticholinergic syndrome, intoxication with stimulants such as MDMA or ecstasy, amphetamines, and cocaine. Infection is a possible etiology of the symptoms and must be excluded. For example, central nervous system infection such as meningitis, or encephalitis. Let's do a case. You're in the pre-anesthesia clinic and you're seeing a 27-year-old male patient who has a history of well-controlled schizophrenia on olanzapine. He's scheduled to undergo knee surgery. This is going to be his first surgery to date. The patient reports a history of neuroleptic malignant syndrome, which was attributed to haloperidol in the past. He doesn't have any family history of anesthetic complications. The patient asks you if he is at increased risk for malignant hyperthermia and whether a specific prophylaxis is indicated for that. So what about the risk of malignant hyperthermia in a patient with history of NMS or neuroleptic malignant syndrome? The current literature suggests that there is no such risk, and patients with history of NMS are not considered to be high risk for MH compared to general population. So what about the management of neuroleptic malignant syndrome? Obviously stop the offended medication, exclude infectious process, for example by doing a lumbar puncture or sending blood cultures or some other cultures. Medications can be used to treat and alleviate symptoms of NMS, good supportive care, and in extreme cases, electroconvulsive therapy or ECT. There are different classes of medications which can be potentially used in the case of NMS. For example, dantrolene, bromocriptine, amantadine, and some adjunct medications. For example, benzodiazepines and dexmedetomidine. So let's talk first about dantrolene. As we all know, dantrolene can also be used in the management of malignant hyperthermia, so there is some similarity. So dantrolene acts as a direct skeletal muscle relaxant. On the left side of the slide, you see the pictorial showing that the dantrolene blocks ryanodine receptors in the cell, which leads to decreased calcium release from the cytoplasmic reticulum. The typical dose of dantrolene for NMS is from 1 to 2.5 milligrams per kilogram, about every 6 to 8 hours. The maximum daily dose of dantrolene should not exceed 10 milligrams per kilogram. There is a potential for liver toxicity, and it is recommended to avoid concomitant use of calcium channel blockers due to reports of profound hypotension and hyperkalemia. The next medication to discuss is bromocriptine, which is dopamine 2 receptor agonist. It is only available in internal form, and the typical dose is 2.5 milligrams every 6 to 8 hours. The maximum daily dose should not exceed 40 milligrams. Side effects include psychotic symptoms, nausea and vomiting, and hypotension. Of note, bromocriptine is also used in the management of Parkinson's disease, acromegaly, and hyperprolactinemia. The next medication to discuss is amantadine. It's a dopamine agonist and can be used in the management of NMS when other medications are not available or contraindicated. Of note, it has some activity against influenza viruses. The maximum daily dose of amantadine is 200 milligrams every 12 hours. Similarly to bromocriptine, it is only available in internal form. Side effects include hypotension, psychotic symptoms, dry mouth, and urinary retention. Dry mouth and urinary retention are usually due to some anticholinergic effects and activity of the medication. There are a few variants of neuroleptic malignant syndrome worth mentioning. The first is Parkinsonism hyperpraxia syndrome. This is typically due to withdrawal of medication called levodopa, and you have to resume this medication as soon as possible to treat it. Another variant or closely related condition is intrathecal baclofen withdrawal. And the management is very similar in principle to Parkinsonism hyperpraxia syndrome, and you have to resume the treatment with intrathecal baclofen as soon as safely possible. There are some adjunct medications of note and importance. For example, benzodiazepines can be used due to the effects on agitation and some muscle relaxation effects. Typical benzodiazepines for this indication here include lorazepam and diazepam. Dexmedetomidine or alpha-2 agonist, can also be used in the management of NMS to control symptoms such as agitation, tachycardia, and hypertension. A good supportive care is essential in the successful management of neuroleptic malignant syndrome. Managing hemodynamic instability with vasopressors if the blood pressure is low and antihypertensive if the blood pressure is high is essential. Extreme cases of hemodynamic instability probably warrant an arterial line and a central venous catheter. Managing hyperthermia is essential. You can do that by controlling the agitation, adjunct use of cooling devices, and extreme cases, general anesthesia with non-depolarizing neuromuscular blockade. Prevention and treatment of acute kidney injury, electrolytes, and respiratory management, for example, intubation for airway protection, or in the cases of aspiration in the RDS. Of note, hyperthermia, if not treated, can lead to many possible adverse reactions, such as disseminated intravascular coagulation or DIC, rhabdomyolysis, central nervous system impairment, and coma. Electroconvulsive therapy, or ECT, is indicated for refractory cases. ECT for patients with NMS may be associated with high risk of complications compared to non-NMS patients. Again, there is very little data to support this statement, but potentially avoid sexual choline for those patients, given the possibility of excessive hyperkalemic release. Let's do a case. This time will be a real-life scenario. We have an 18-year-old female who has a history of depression on phenelzine. She came to the emergency department with fever, intermittent agitation, and unexplained jerking movements. She was admitted to the hospital for suspected viral syndrome and was given meperidine, aiming to elevate her jerking movements. Unfortunately, she didn't get better, but rather worse, requiring restraints and haloperidol. The next morning, her temperature was found to be 107 Fahrenheit, which is approximately 41.6 Celsius, and she soon developed cardiac arrest and unfortunately died. The patient's name was Libby Zion, who unfortunately died on the 5th of March 1984. Several state and federal trials took place from 1986 to 1996. The main message of this trial was that the residents were overworked and taking care of so many patients that they could not give enough attention to Libby Zion, which led to her death. In 1989, New York State adopted 80-hour-a-week rule and no more than 24 consecutive hour rule for residents in training. In July of 2003, ACGME adopted similar criteria for resident duty hours, which is in place nationwide. That is why you have to report your hours every week. So serotonin syndrome is a major side effect of serotonergic medications, and as we saw in the case of Libby Zion, a prompt recognition and management is essential to a successful patient outcome. So let's talk about the serotonin metabolism. The serotonin is derived from an amino acid called tryptophan, and on the right part of the screen you see different steps and different enzymes responsible for the conversion of the subsequent chemical. Monoamine oxidase, or MAO, is an essential enzyme in metabolism of serotonin. Here on the left part of the slide, you see the schematic of a synapse and the postsynaptic membrane. And here you can see the metabolism and reuptake of serotonin. Please take a second to review this image. So let's talk about pathophysiology of serotonin syndrome. There are a number of different serotonin receptors. It is believed that receptor number 1A and 2A are essential in the pathogenesis of serotonin syndrome. Another name for serotonin is 5-hydroxytryptamine. That's why 5-HTA is written here. Serotonin affects multiple things, including behavior, temperature control, GI motility, vascular, bronchial, and nutrient tone, explaining the myriad of different patient presentation which can be seen in patients with serotonin syndrome. Let's talk about the culprit medications which are responsible for the development of serotonin syndrome. The mechanisms by which these medications lead to serotonin syndrome can be broken down into several groups, such as impaired reuptake, decreased metabolism, serotonin agonism or serotonin agonistic effects on the receptor, modulation of the serotonin receptor, increase or modulation of serotonin release, and enhanced synthesis of serotonin. Of note, some medications or drugs can lead to serotonin syndrome due to more than one mechanism. For example, MDMA or ecstasy, a drug of abuse, can lead to serotonin syndrome due to modulation of the release of serotonin as well as reduced reuptake. Some medications such as opioids, which are frequently used in anesthesia practice, can lead to serotonin syndrome. It's important to remember that methadone, meperidine, tramadol, and fentanyl are commonly associated with serotonin syndrome. If you remember that our patient from before, Libby Zion, was taking phenelzine for depression, which is MAO or MAO inhibitor. When she presented to the hospital, she was given the medication called meperidine, which likely contributed to her clinical deterioration. Again, please take a second and review this table. So again, what are the risk factors for serotonin syndrome? Again, it can happen or occur in any patient taking serotoninergic medication, but more commonly it's seen in patients who recently increased the dose of their medication or use 2 or more medications which have serotoninergic effects. So what about the clinical presentation? It's typically associated with a rapid evolution of symptoms after either an initiation of treatment or increase in the dose of serotonergic medication, typically within 24 hours or even sooner. The signs can be CNS agitation, anxiety, seizures and coma, sympathetic system hyperactivity such as increased temperature, increased heart rate, increased blood pressure, sweating, nausea, vomiting, diarrhea, and mydriasis or dilated pupils. Neuromuscular symptoms and signs can include clonus and hyperreflexia. So what is a clonus? It is an abnormal reflex which is involuntary and rhythmic. Here on this video you see an induced clonus reflex. And this picture you see different signs which you can observe in the patient with serotonin syndrome. Serotonin syndrome is a primarily clinical diagnosis. Hunter criteria can be used to aid in the diagnosis of serotonin syndrome. Several questions need to be answered, such as, for example, is the patient taking medication which is associated with serotonin syndrome? Does the patient have clonus? And again, some other symptoms and signs such as agitation, temperature, and diaphoresis. Again, there is no specific laboratory test which will diagnose or rule out serotonin syndrome. The tests which you can order are typically used to screen for complications or alternative diagnosis. On this slide, you see some possible tests to order. For example, lumbar puncture may be considered when you're suspecting a central nervous system infection. Also, imaging such as brain imaging can be considered if you are trying to rule out other structural brain problems presenting and mimicking serotonin syndrome, or such as, for example, cerebrovascular accidents. Microbiology data outside of lumbar puncture can also be considered to exclude infection in these patients. The differential diagnoses of serotonin syndrome include neuroleptic malignant syndrome, malignant hyperthermia, sympathomimetic intoxication, anticholinergic toxicity, and thyroid storm. The management of serotonin syndrome consists of stopping the culprit medication or medications, use of benzodiazepines. Serotonin antagonists or cyproheptadine may be considered in extreme cases, and the good supportive care is also paramount. Benzodiazepines can be used in the management of serotonin syndrome due to their sedative actions and some muscle relaxant properties. Typical benzodiazepines used for this indication include lorazepam and diazepam. Cyproheptadine is a medication which can be used to antagonize excess serotonin. It is an H1 or histamine 1 blocker. It also blocks serotonin 1A and 2A receptors and has some mild anticholinergic properties. It is only available in enteral form. The typical dose is 12 milligrams, followed by 2 milligrams every 2 hours if needed. Possible side effects include hypotension and sedation. Dexmedetomidine can be considered instead or in addition to benzodiazepines. There is some data to suggest that it may reduce the release of serotonin, and again, it can lead to sedation and reduced sympathetic tone, which can be favorable in this patient population. Good supportive care is essential. It is very similar to good supportive care which we discussed for neuroleptic malignant syndrome. Please take a second to review some of the possible treatment options. So what about the medications to avoid? Butyrophenons, such as for example haloperidol, should not be used to control agitation, primarily because it impairs heat dissipation and potentially can cause further hyperthermia. Remember that haloperidol was used in the case of Libby Zion. Dantrolene, bromocriptine, and amantadine are unlikely to be effective and not cost-effective and don't have good risk-benefit ratio for patients with serotonin syndrome. Long-acting antihypertensives, such as for example propranolol, should not be used due to potential for prolonged hypertension and bradycardia. On this slide, we'll discuss the differential diagnosis of three conditions: serotonin syndrome, neuroleptic malignant syndrome, and malignant hyperthermia, or MH. The onset, neuromuscular findings, etiology, treatment, and a typical resolution is also presented. Serotonin syndrome typically evolves rather rapidly, usually within 24 hours of exposure. Compare this to days to weeks in patients with neuroleptic malignant syndrome. Malignant hyperthermia onset is variable because there are reports of patients who have MH who had uneventful exposure to inducing agents in the past. Neuromuscular findings such as clonus and hyperreflexia are typical for serotonin syndrome, whereas muscular rigidity and brachyreflexia are more common in MS and muscle rigidity in malignant hyperthermia. The etiology of serotonin syndrome is serotonin agonist medications, dopamine antagonists for neuroleptic malignant syndrome, volatile anesthetics such as, for example, isoflurane, sevoflurane, halothane, and desflurane, as well as acetylcholine, are medications associated with malignant hyperthermia. The treatment for all includes the stop or cease administration of the offending agent. Benzodiazepine and cyproheptadine, the treatment of choice for serotonin syndrome, bromocriptine and dantrolene for NMS, and dantrolene for malignant hyperthermia. Again, it is essential that the offending agent is stopped for all of those conditions. Typical resolution is within 24 hours for serotonin syndrome, days to weeks for NMS. For MH, it is variable, but typically it resolves within several days with successful treatment. So in summary, both neuroleptic malignant syndrome and serotonin syndrome are quite rare. They have somewhat similar clinical presentation. However, exposure and certain clinical findings help in differentiating these two conditions. They are not considered to be risk factors for malignant hyperthermia per se. Prompt clinical recognition, good supportive care, and antidotal treatment is essential for favorable patient outcome. Thank you very much for your attention. If you have any questions, please feel free to email me on the email address provided on the slide. All the best to you and good luck.